Yeah, so I guess we can
اتفضل حضرتك.
take questions live if anyone want to ask any question to Professor Alaa. My question, Professor Alaa, I always have a problem, especially lately here in Kuwait. They stopped us from doing tumor marker for patients on follow-up. I would like to know what's
Okay.
your practice and
Actually,
guideline?
this is a very important question, and I will do it answer in a little bit funny way. Actually, we don't really do it, but actually, while a great deal of our clinical practice in the private area, so our patients do insist, and even if you don't ask them to do it, they go and do it and ask you, why is my CA 15.3 rising like it was 21, now it's 23? What's the big deal? You know, things like that. So, I mean, but routinely wise in the university practice, I really don't do it that regularly. I agree with you.
Any questions to Professor Alaa?
Send you a
Okay, so
note
I
by
send you a question, Faisal.
okay.
Just to ask Dr. Alaa, you know, the
Yes.
patient was given LHRH and analog plus abemaciclib, I assume with the Faslodex, right? Or single agent?
Oh yeah, with fulvestrant. I'm sorry, I didn't.
Okay,
that
that's missing
slides
on
were
the
edited
slide.
by Abib.
It's missing on the
Oh
slide.
yeah, yeah.
That's what I assumed.
Yeah, sure. She had a hormonal
Okay.
companion, you know. Oh yeah, oh yeah.
This was my question also.
Yeah. Okay. Then she can go on
I
AlaaAlexandria.
assumed it was dropped from there.
Yes.
Okay, so we'll move. We have time, so I guess we have about 20 minutes, and we'll move to Professor Marwan Ghosen, who's director of the Cancer Center and the head of Oncology and Hematology Division at the Clemenceau Medical Center, which is affiliated with the Johns Hopkins International in Beirut, Lebanon. Recently, he also joined the Clemenceau Medical Center in Dubai. He is author and co-author of more than 200 peer-reviewed articles. Professor Marwan, I'm so glad that you're going to present to us, and I'll try to challenge you with some question. Please take the mic.
Thank you very much, Faisal, for this very nice introduction. And thank you for my previous speakers who elegantly discussed the case and introduced the subject, which is really a hot topic currently. As I'm presenting from Beirut today, I couldn't begin my presentation after giving my disclosures. These are my disclosures. I couldn't begin my presentation without at least saying that we still remember also, despite and moreover of the COVID-19 pandemic, what really happened in our country 2 months ago. We will continue to remember, and our participation in these very elegant lectures is only to say that we are here to continue, and we will continue to support the medical and the healthcare system in our country, in our region. This is the case. This is a very recent case that I have to present. It was during the pandemic. So just imagine we were in the pandemic, we were in a lockdown situation in Beirut, and we had a very huge psychological pressure on us, especially from our patients who are metastatic and from their families. And we needed to act rapidly, and we needed to have responses very fast, as you imagine in these kinds of situations. So this is a fairly young patient of 57 years old female who presented with cervical and sacral pain, which were misinterpreted for a few weeks and even maybe 1 or 2 months. There is nothing in her medical history except a ankylosing spondylitis and a nevitis, which was treated by Remicade in August 2019. She presented to her screening mammography in 11 of February 2020, just before the lockdown. She had she had a right axillary lymph node on the mammography of 1.6 centimeter with some inflammatory appearance. This wasn't followed up, and 1 month later, she had a worsening and a huge debilitating pain in her neck and her back pain with major functional impairment. The patient wasn't even able to walk again without any history of trauma. She was brought to the hospital on an emergency basis, and a rapid MRI of the whole dorsal spine revealed an impressive osteotic lesions in the vertebra with a fracture at the C6 level with spinal cord compression, as well as multiple severe other lesions in the cervical and the dorsal region. Rapidly, a total body CT scan was performed, and it revealed the diffuse lytic lesions, but really they were very diffuse. And the patient underwent, on an emergency basis, a surgical decompression and stabilization of the cervical spine, C5 and C7. This is just one slide to show you that it was really a severe narrowing and compression by an osteotic lesion at the level of C6. During the decompression, the pathology revealed a highly grade, poorly differentiated adenocarcinoma. After immunochemistry, it was consistent with a primary breast cancer. In fact, at the pathology, ER receptors were highly positive in nearly 90% of the tumor cells. PGR receptors were negative. HER2 was negative by FISH testing. And we did, after the decompression, a PET CT scan which showed the highly uptake of the right axillary lymph nodes within the diffuse osteolytic lesions without the primary evident in the breast and without any other localization. She had rapidly also 10 sessions of palliative radiation therapy on the surgical site, as well as one lesion in the sacrum with some clinical relief, at least in the pain, but not in the functionality of the patient. And this was the lumbar MRI showing the site where some radiation therapy were also given at the same time after the decompression of the C level. Patient was still in the hospital, debilitated, went with home care at home, and this was a postmenopausal patient with a metastatic high-grade. Remember that the adenocarcinoma was undifferentiated, high-grade breast adenocarcinoma with extensive bone disease. So at this point, I needed to ask what could be and what were my options of treatment for this patient. Please scan this icon in order to be able to participate in the voting. And of course, should we go for aromatase inhibitor? Should we go to abemaciclib as monotherapy? Abemaciclib plus aromatase inhibitor, or maybe also combine it, but I didn't put it with another CDK4/6 inhibitor. Okay, elegantly, the audience is giving us the combination between CDK4/6 inhibitors and aromatase inhibitor. And in this particular case, I proposed abemaciclib because of the very high-grade aggressiveness of her disease and the presentation with debilitating bone metastasis. For me, it was like a visceral crisis of the bone, if you understand what I'm talking about. So this was, I'm moving my slides. It's very slow, but I'm moving the slide. I'm trying to move the slide. If I can have any support by moving the slide forward, it would be great. Okay, so I elected to give her abemaciclib plus aromatase inhibitor. I recall the Monarch 3 trial, which was previously presented, combining aromatase inhibitor with abemaciclib versus placebo with abemaciclib, with the primary endpoint progression-free survival. These were patients who either progressed on who previously received endocrine therapy during neoadjuvant or progressed on adjuvant setting, and the patients you see here the baseline characteristics of the patients on the intent to treat analysis. As you see, there were measurable disease in the majority of these patients. In these patients, few of them were only loco-regional recurrence. A lot of them, nearly 50% plus, were metastatic recurrent, and 40% of these patients were, like my patients, de novo metastatic patients. In this particular trial, more than 50% of patients had visceral involvement, and also 25% of the patients has 21% of the patients has bone only. Also, please remember that nearly 40% of these patients were already receiving or were exposed previously to neoadjuvant or adjuvant chemotherapy, and also 20% of these patients received other endocrine therapy, and 25% received aromatase inhibitor in the previous treatment. Also, the treatment-free interval of these patients in 50% was less than 3 years. So patients who were included in the trial were still on their adjuvant hormonal treatment. As you see, can we go back? Yes. As you see, for the progression-free survival, 28.8 months for the patients who received the combination with abemaciclib versus 14 months for the patients who received placebo plus an aromatase inhibitor. And in fact, it was an impressive hazard ratio of 0.54, highly statistically significant. We don't need statistics for these kinds of figures. And if you look to the overall response rate, also we had much more overall response rate in the patients who received, who received the combination, also with more than 60% of the patients who responded. The patient then was started, as I previously said, on abemaciclib, 150 milligrams twice per day in combination with letrozole and zoledronic acid. And very rapidly, we began the treatment in May after the end of the radiation therapy and after the patient was able to get the drugs. Remember, we were in COVID-19 lockdown, and rapidly the patient improved clinically. I would say it was a dramatic improvement clinically, with the patient recovering her functionality and her mobility. And we did a PET-CT scan only 2 months and 2 weeks, like 10 weeks after the initiation of the treatment. And we documented on the PET-CT scan, a very rapid response to this patient with a dramatic improvement in the FDG uptake with the drop of the SUV of all her lytic lesions, the one who received the radiation therapy, of course, but moreover, the ones who did not receive the radiation therapy. And in fact, it was a very rapid response to this treatment. I would like to rediscuss the patient once again, knowing that this patient was only in kind of bone visceral crisis. Please scan again the icon in order to participate in the voting. The fact that this patient didn't have liver metastasis and visceral metastasis, and I gave her abemaciclib. But assuming that the patient had liver metastasis at the beginning, would you go for visceral metastasis, including liver metastasis? Would you rather go to chemotherapy, or would you still go to the hormonal therapy? You know, until recently, this kind of patients with visceral crisis or nearly a visceral crisis or a visceral-like crisis, we would like to go to chemotherapy rapidly. But now, with the new data that we have, do you still go to chemotherapy, or you would also favor the combination with abemaciclib with aromatase inhibitors, like most of us or some of us are doing nowadays? Okay, I see that everybody agrees with the use of abemaciclib combination. And in fact, as you see, and in fact, if we go again to the data which was shown in Monarch 3 trial, please can you support me in moving the slide? I don't know if it's not going. As you see, and I have previously said, more than 50% of the patient has visceral involvement, including liver involvement. And of course, other patients had bone-only disease. And if we go to the progression-free survival for the patients who did not have liver metastasis, and for the patient who had liver metastasis, as you see very nicely, the curves are completely different. And the use of abemaciclib in this particular subgroup of patients was positive. If we move and we look also to other variables of poorer prognosis of the patients who were included in Monarch 3, you see when the treatment-free interval was less than 36 months versus than more than 36 months. In the patients who had less than 36 months, we had an improvement in the progression-free survival. And also in the next slide, you will see the tumor grade. The patients who had a higher tumor grade had a greater benefit of this combination, making it a very nice tool to use in this subcategory of patients with poor prognosis features at their presentation. I would say that the safety, we didn't see any particular safety issues dealing with these patients. And in fact, for my patient who was immobilized at the beginning of the treatment, I had the fear that she would get so many diarrhea symptoms and syndromes and not being able to move from her bed in order, to go to the bathroom. But in fact, in this particular patient, I didn't, the diarrhea was nicely managed, and we went on to go and stop when we saw that the diarrhea was more intense, and I was not obliged to drop the dose, and she is still continuing her current treatment with the same dose of 150 milligram, giving twice per day. And I just saw her last week for her zoledronic acid injection, and she was beautifully coming on her foot to our outpatient department, and she was really happy with her response. And this is exactly what I still said. And in fact, the discontinuation of the drug as a result of the diarrhea in Monarch 3 was only 2.3%, and this is exactly what I saw with my patient. So in the conclusion of the Monarch 3, and this was the same conclusion for my patient, that the patient has benefit, they have an overall response rate, they have a nice progression-free survival, and they get a benefit from the combination of abemaciclib with aromatase inhibitors. And the responses occurred early in the Monarch 3, and this is exactly what I saw with my patient, and the drug was well tolerated. Of course, you need to proactively manage the patient and support the patient morally. And in this particular case, during the lockdown, we needed also to support the family. Thank you very much for your attention.
Thank you very much, Professor Marwan. Well done. I have a question to you. I can see the textbook, there isn't questions. Do you think the COVID did the COVID era affected your choice of CDK4/6?
This is a very nice question, because this was our challenge during the COVID-19 pandemic, and the international recommendations, including the ASCO, our Lebanese Society of Medical Oncology recommendations, other recommendations coming from Emirates also in the region, and of course from Egypt, recommended to use hormonal therapy as much as we could during this pandemic, and to spare for our patient the chemotherapy. So of course, I was pushed to use the endocrine therapy during the COVID, but particularly for this particular patient, I did not hesitate to use abemaciclib, knowing the results that we had with the Monarch 3. And I was very easily prescribing the drug. I didn't even think of giving chemotherapy. But for other patients where maybe they could be more challenging cases, I know that my colleagues and myself were facing with this dilemma to spare the chemotherapy and to use hormonal therapy. But with these new drugs who are really very effective, I think that our dilemma is getting lesser and lesser every day.
Okay, thank you so much. So I because Professor Cortez has got another meeting starting, so he thanks everyone, and
we thank him very nicely for his nice presentation and his nice participation, and for his continuous support to our region and to his friends in this region.
Okay, professors, I have a question to everyone. Professor Alaa, Marwan, do you think, I'm sure you're aware of the, but from your experience, is it true when you combine CDK4/6 or abemaciclib with hormonal, you get less side effect of the hormonal therapy, the hot flushes, what's your experience in that?
Alaa, you need to unmute. Unmute, Alaa.
Can you hear me now?
Yes,
yeah.
We hear you really well.
Well, this is a very good point, actually, sir, and I totally agree with that. But again, I cannot conclude this is an impression. This is my only personal experience. So yes, I do agree with what you say. Yes.
I think I didn't use. I only have 3 patients of abemaciclib, but I have used a lot the other aromatase inhibitors also in combination with CDK4 and 6 inhibitors. I think that we stress so much on our patients on the side effects of the CDK4 inhibitors that maybe they are, they don't think anymore of the other side effects. We stress because each CDK4/6 inhibitor has its particular, profile of side effects. We stress so much on them, maybe they are forgetting the other side effects, but still it is an impression that they have less other side effects from their aromatase inhibitors.
Exactly.
Yes, true, and especially I think we will struggle, or we will notice probably the CDK4/6 side effect when we're gonna start using it in the adjuvant setting, because in the metastatic they have disease, they're happy to see there is a response in the PET scan, but in the adjuvant when there is no disease to see, I think we're gonna come across a lot of struggling with the side effects.
Agree.
Yeah, I totally agree with you, but hopefully we have the same consistent data that we have in the metastatic setting with the 3 CD4/6 inhibitors. As you've seen in the last ESMO, we have contradictory data. I mean, Palbo didn't work in the adjuvant as per the Palace trial. However, Monarch E was very significant and when it was very positive. So hopefully time will tell.
Hello, dear professors. Sorry for interrupting. I'm just reminding that it's now off label, so we couldn't discuss it anymore until we have it. We have the approvals.
Sorry, Professor Nadia, we couldn't hear you clearly. Can you say that again? Can you repeat that again?
Hello? Yes, you hear me?
Yes.
No,
Yes, we hear you.
Yes,
We
Nagri,
hear
we
you,
hear
Nancy.